Good afternoon, everyone. Thank you to both professors for the introduction, but also for the mentorship that I've received over the years. I think I'm very privileged that I can call both of these my mentors. So picking up from where Prof. Mulenga left off, just a quick overview of my presentation. We'll look into the clinical guidelines, obviously looking at the different medications, but we really want to make it practical. How do we actually apply these guidelines in the wards where we are working? So we will look briefly at the risk stratification, the different treatment pathways, quickly over the inpatient and outpatient therapies, and lastly, we'll touch on the test and treat for COVID-19. Of course, I have no disclosures to make mention of. One of the things that I've been asking, and I know Dr. Nyambe spoke on it in the morning, is why are we still talking about COVID? Particularly for me coming as a cholera coordinator, I think it's really important for us to know the lessons that we learned in COVID are some of the lessons we're taking in other diseases such as cholera, but also the fact that we still have COVID across the country. Yes, not as severe, but we do have COVID, and hence the importance of us understanding how to treat the patients. I won't go into this one too much because it's quite a busy slide, but it's in all our case management guidelines, just showing the different treatment pathways available for patients. And we stratify our patients according to their severity of disease. For those who are asymptomatic with no risk for progression or comorbid conditions, they are managed for 7 days at home. For those who are asymptomatic but have high risk with comorbid conditions, would want to review them early, at least within 5 days. And then for the bulk of this conversation will be on those with non-severe disease but with mild symptoms and risk of progression due to their comorbid conditions versus those that actually have severe disease and may actually need to be hospitalized. So in terms of risk stratification, you want to look at your different treatment eligibilities for your patients. Often we focus on the patients with comorbid conditions, but there's other patients that you'd want to consider as high risk for progression and hence need for treatment. I think in the morning we had a very detailed session about vaccinations and the benefits of vaccinations. So people who are not vaccinated definitely would be those you'd consider for early antiviral treatment. Of course, we've mentioned those with comorbid conditions existing with COVID-19. A particular comorbid condition that we don't really focus on is people who are overweight or obese. I think those of us living in Lusaka, obesity is the next epidemic that we actually need to pay a bit more attention to. Of course, pregnancy, children, people in correctional facilities, those with disabilities, as well as those that are homeless. We often forget about patients who are homeless and on the streets and whether or not they do need to be eligible for certain treatments. And this, again, is a very long list of the particular comorbid conditions that patients with severe disease could have, and those that even before they're severe need to be treated with an oral antiviral therapy. Again, this is available in the guidelines, and the slides will be distributed afterwards so that we don't need to delve too much into them, but we will focus on a few of them as we go along. So coming back to the overview that Prof. Mulenga left us with, we did discuss briefly the different types of treatment. There's the supportive treatment, the treatment that's particularly for the non-severe disease, and then we'll go into it later, the treatments for severe patients. And then in terms of our treatment pathways, we want to look particularly at how quickly did the patient present to your facilities. So for those who've presented beyond 5 days, they are beyond their treatment window. Remember, you want to catch the virus early and treat them within 5 days with the antivirals, particularly the nirmatrelvir, ritonavir, as well as remdesivir, which are available now. And then for patients who have slightly more severe disease, when we look at their different vitals, you realize that they don't qualify for Paxlovid, for example, and there's other treatment options that should be given to those patients. The last one that's on my list of outpatient therapies for non-severe disease is molnupiravir, and I will go into it in a bit to see, whilst it's in our guidelines, it's not readily available in country. You'll notice that one of the biggest issues with molnupiravir is the issue of pregnancy. And remember, we say that every woman of childbearing age is pregnant unless proven otherwise. Molnupiravir has issues with teratogenicity. And so when the committee was making the guidelines, it was one of the things we considered, and we didn't prioritize that as a treatment for patients within Zambia. So summing up what the previous slide was saying, just looking at the different therapies that are available for outpatient management, and just to make mention that these guidelines, that the Zambian guidelines that were released early last year and are actually about to go under review for this year. One of the main things that we did want to highlight was the treatment for outpatients, but also the fact that these guidelines are based on evidence from randomized control trials done in other countries, but we have been doing observational studies in country, and we'll look at them in a minute to see some of the findings that we've made from our patients that are available, that have been treated locally. So starting first off with Nematrevia ritonavir, or Paxlovid as we know it, the evidence is there from trials such as the EPIC-HC that does show that Paxlovid does reduce your duration of symptoms, and also if it has a proven safety record through to 34 days. And so this was a study that was comparing patients that were given Paxlovid or placebo, and they did find that the number of adverse events was slightly reduced, but also more significantly was the patients with the side events, with severe adverse events was reduced in the patients who received the Nematrevia ritonavir compared to those who had placebo. And another important finding was the fact that Paxlovid does have a bitter taste as a side effect that often patients don't like, the dysgeusia, but fortunately the studies have shown that it's not enough to affect how they complete their treatment. You will notice that also there's evidence for Paxlovid and its use in the Omicron stage of the virus. Earlier on in the outbreak, we had different monoclonal antibodies that we're using in different patient populations. These have fallen off in our guidelines since there's evidence that they do not actually reduce duration of symptomatology for patients. However, with Nematrevia, it has been shown to reduce the duration of symptoms for the patients, and also was able to reduce the progression to hospitalization and death, which I think is a very important thing that Prof. Mulenga had touched upon when we looked at the rationale for why we are advocating for outpatient therapy for patients. And another study that was also done in the United States, showing the effectiveness of Nematrevia ritonavir, basically reducing the severity and the mortality benefits of this study. Another outpatient therapy that is available in country, again, Prof talked about how he was our first guinea pig to show that remdesivir given for outpatients has been shown to, again, reduce the progression of symptoms as well as the risk of hospitalization. But it's very important to note that it has to be given within the first 7 days of symptom onsets, so slightly longer time period than the Nematrevia, which has to be given within 5 days. However, the complications with using remdesivir is that unlike the Nematrevia, remdesivir is actually an injection. It has to be given intravenous over a 30-minute time period. And so it means even in your different facilities, as you consider which option to use, those are some of the limitations, because this will be an outpatient, but on intravenous therapy. Hence why I think the use of remdesivir has largely been kept at the large teaching hospitals as well as in inpatient wards. So I touched on this briefly, just looking at some of the challenges of using remdesivir for outpatients. And then now coming to our operational research that we've been doing in some of the sites across Zambia. We have 13 operational research sites that have been giving Paxlovid since the beginning of last year, so almost a year now. And we just wanted to document how the patients were being treated, the symptoms. So for example, we found that in terms of eligibility, 68% of the patients that we saw across the country had mouth symptoms and hence met the eligibility criteria. Unfortunately, there's 24% with missing data, so just a really important reminder that it's really important for us to continue to document the patient symptoms, the patient findings, even as we adjust our guidelines according to how the patients are treated. In terms of the presence of risk factors, we did find that at least 55% of all the patients that were seen across the country had at least one risk factor for progression. So those are the risk factors mentioned earlier, such as hypertension, diabetes, particularly obesity, and not being vaccinated. The number one risk factor, though, amongst our patients, of those who presented with mouth symptoms at any of the 13 sites, was age above 50 years old. Other risk factors that were found was HIV positive, TB, obesity, and diabetes. And then for most of the patients, at least 48%, they were seen within 5 days. Unfortunately, again, the data was, we had about 49% missing data amongst the patients that were seen. And so in general, there's certain considerations you'd want to be mindful of as you give the nirmatrelvir-ritonavir, particularly for patients with HIV. We will discuss later, I think, in the panel discussion, some of the drug-drug interactions that can occur with Paxlovid in particular. And you'll notice that it's nirmatrelvir with ritonavir. Fortunately, there's no drug interactions with the ritonavir, and so it can be given to patients who are HIV positive without any dose adjustment. For patients with tuberculosis, there were concerns about rifampicin, and so there is consideration in those patients to give them remdesivir as an alternative if it's available. For patients with renal impairment, you'd want to adjust your dosage because it is cleared renally. So for those who have mild renal impairment with an eGFR of about 30 to 59, you would give them the standard treatment, rather the half treatment dose, 150 milligrams, as opposed to 300 milligrams of the nirmatrelvir. However, if they have severe renal impairment with an eGFR less than 30, you would choose an alternative option. And then for those with severe hepatic impairment, there's no contraindications. I touched briefly already on the molnupiravir and the concerns for pregnancy. In other countries, they do give contraception considerations, but for us, it's not currently available in country, as we already discussed. Important to note, though, in our guidelines, there's mention of the drugs that are no longer recommended. I think some of these on the list, we used to use them very broadly. If I was to just take a quick show of hands, how many of us ever took azithromycin when we had COVID? Anyone? Most of us. And suffice to say, it was in our previous guidelines to give azithromycin. So one of the things that make living guidelines so important is that the evidence does change, and we know now that, I guess we knew then, that COVID was not a bacteria, and so really there was no role for antibiotics to be given in terms of treating an antivirus. So that's something that has come out clearly in the guidelines, that we are no longer advocating for the use of azithromycin. There's certainly other complications that have arisen due to antimicrobial resistance. Of course, there's also people taking prednisolone and dexamethasone as outpatients. Again, those are not being recommended. And then some of the more controversial things like ivermectin and hydrochloroquine, we do have strong evidence that has been generated that those drugs do not work. So really quickly, before I run out of time, just want to highlight again that there is evidence, even local evidence generated from our COVID outcome study, to show that there's really no role for antibiotics in patients with COVID-19, unless that patient is admitted and has a comorbid bacterial infection. For the severe COVID patients who end up in ICU, they do tend to have, they can have community-acquired pneumonias, and those are patients who would need antibiotics. However, for outpatients with no clinical signs, by clinical signs, we can use just a clinical CURB-65 score. If their CURB-65 score does not suggest that they have a pneumonia, there is really no role for the antibiotic. And so in the COVID outcome study, we did try and see how many patients had antibiotics that were inappropriately prescribed. We had over 89% of patients receiving some form of antibiotic, even for less than most of them for less than 3 days. So just to really underscore the importance of assessing your patient, if they do have a bacterial infection, according to the assessment, antibiotics are warranted for that infection. However, if you're just giving the antibiotic for the sake of saying they have COVID and you want to give them something, that's why we do now have these outpatient therapies. So shifting gears a bit to quickly touch on the treatment for severe illness. I know the expectation is to talk about some of the complicated drugs, but actually I want to talk about the nursing care for COVID patients. Yes, we have a lot of very expensive, very effective drugs, but really the thing that will keep your patient alive is a team approach, and really the backbone of the team is the nursing officers responsible for the ward. would like to admonish young doctors like myself. Often as the young doctor on the team, you want to think that you're the team leader and you know everything, but please, let's listen to the nurses. They have a lot of experience and they really can keep your patient alive if we are humble enough to pay attention to what the nurses are telling us. So when we talk about the ABCD approach, thank you for that. I can see some of the nurses who've taught me a lot of things, very excited. But just to say that, yes, as much as we have these expensive drugs, we do need to be mindful of the team approach and really bearing in mind the basic ABCs of how we manage our patients. Make sure that your patient's airway is patent. Especially with COVID, you'd find sometimes the patient is not talking, is not breathing, but was so fixated on what drug is available. When it comes to breathing, the SpO2 has to be measured and rechecked frequently, so that you're always mindful that the oxygen is actually running. Sometimes you'd have situations where there's a blockage in the tubing, and if you're not paying attention to those small things, you may actually end up losing your patient. In terms of circulation, we have to be, like we mentioned, a lot of the inpatients who we admit have comorbid conditions such as hypertension, so sometimes you may need to control the blood pressure, but then if your patient is very sick, they may actually be in shock, and so each patient is managed on a case-by-case basis. Additionally, you'd want to monitor for signs and symptoms of other complications, such as venous thromboembolisms, which are very common in COVID patients. Basically, your COVID patients can often present with strokes, DVTs, pulmonary embolisms, and coronary acute coronary symptoms. Hence why drugs such as heparin or your enoxaparin is so important. Once your patient is admitted, it's important to monitor their D-dimers and make sure that you're monitoring the levels to adjust the dosage to therapeutic levels. Again, with COVID patients, something else that was very common for the admitted patients was delirium. Patients would present and become confused, and again, admitting as a clinician would get irritated that the patient keeps taking off the mask, and you get really upset, like, why are they taking off the mask? But it was really just a symptom of their severe disease, and it's important to be mindful of it as you manage your patients and have conversations with them. You even need to make sure that the environment where you're keeping your patient is one that actually encourages them to talk to. You need to be talking to your patients. You need to basically increase their sensory input so that the patients are not prone to get delirium. Again, the patient environment, which is the E in our ABCDE approach, very important to make sure that we are turning our patients, we're making sure that they're getting oral care and some of the basics of hygiene that we tend to forget when a patient is very severely ill. And the management of fluids, making sure that we're monitoring their input and output chart. And remember, we said a lot of our COVID patients have comorbid conditions like diabetes, so you want to be mindful of their glycemic control. So I will skip over most of the very specific drugs that are being used for the management of patients, because often these drugs are used in ICU. But just to talk about them briefly, there's the baricitinib, which we do know is a Janus kinase 2 inhibitor, and it has been approved by WHO. So for patients who have made it with the severe disease, they've been admitted, they've already been started on oxygen therapy because they are sick enough. They do not need to be on Paxlovid, which we said is indicated for mild outpatient therapy. So you can start them on baricitinib, which is available. And then the dosage for your baricitinib, it should be given as, should be 400 milligrams, a single tablet, but then you want to be mindful of the renal adjustments that can be made. You can give your baricitinib with dexamethasone as your primary corticosteroid, or if available, you can use it with tocilizumab as an alternative. And so baricitinib is indicated for all hospitalized patients with severe disease and have elevated inflammatory markers, but are not on any mode of ventilation. And the dosage is there, 4 milligrams, as opposed to the 400 that I'd mentioned. Given for a period of 14 days, whether they are admitted or if they get discharged, they can continue, they can discontinue if they get discharged. The next drug that we would want to make mention of is tocilizumab, which is an interleukin-6 inhibitor, receptor blocker rather, as well has been approved for COVID, as well is available in country. And with baricitinib, it's given for people above the weight of 30 kgs, given at a dosage of 12 milligrams per kg as an infusion over 60 minutes. And the maximum dose you can give is 800 milligrams. For those for those greater than 30 kgs, you'd give it as 8 milligrams per kg as an infusion. For those less, you'd give a slightly higher dosage. You would want to avoid giving tocilizumab in patients with severe immunosuppression, particularly those who have had a recent kidney transplant, for example, and are on biological immunomodulating therapy. The thromboprophylaxis I talked about briefly, mentioning the enoxaparin and how you'd want to give it firstly as prophylaxis, but also to avoid, to make sure that we're avoiding patients developing DVTs and other symptoms. So, Chair, I'll ask just for 1 minute to quickly just talk about the test and treat strategy, just to mention that the very severe patients who end up in admission, if we had found them earlier, they wouldn't need to have severe disease because we do have these alternative therapies available, and hence the encouragement to make sure that we are testing our patients. I think as the COVID numbers have gone down, even our testing has become really lax. So when we look at the very high positivity rate in places like Copperbelt, it's particularly because the number of tests being done are few, and hence those few tests are coming out positive are a lot. So just an encouragement that for especially inpatient medical wards, we need to be testing our patients more routinely so that we're also able to give them appropriate treatment. So the test and treat strategy was officially launched December 2022 by the Minister of Health, and we have been deploying it in different provinces across the country. It was initially in the operational research sites, but now the therapies are available at ZAMSA to be ordered. And I think the last slide I will touch on is just the reason why we've adopted test and treat is to help us break some of the inequalities that we're talking about in the morning of access to not only vaccines, but also to some of these important therapies. And so as much as test and treat is available in the provincial and the district hospitals, we do hope that it will be rolled out into some of the smaller sites. And I think with telemedicine, we'll be able to have more access to some of these therapies. Thank you very much.